Good afternoon, everyone. I hope you're doing well and excited for today's webinar. Today's webinar is going to be on integrating psychodynamic and cognitive behavior therapies in the treatment of obsessive-compulsive disorders. This session will explore the therapy for obsessive-compulsive disorder, integrating psychodynamic and cognitive behavioral therapies to assist clients whose symptoms underlying emotional issues, both that benefit from behavioral and insight-oriented interventions. Client case examples will be discussed to highlight the theory and interventions. We are very honored today to have Dr. Scott Friedman, who's been practicing psychology since he received his doctorate in 1983. He has a bachelor's degree in psychology from Brooklyn College, and he earned his doctorate of psychology, his PsyD in clinical psychology from Heinemann University in Philadelphia. He is trained in psychiatric hospital, an outpatient psychiatric clinic, a day treatment program for adolescents, and at a university student counseling center. He's a licensed psychologist in the state of Georgia and a diplomate in clinical psychology from the American Board of Professional Psychology. Dr. Friedman is a full-time faculty member and a course lead with Yorkville University MACP program and teaches and consults and supervises for Walden University's doctoral program in clinical psychology. He sees clients in individual, couples, and family therapy. He also conducts psychological evaluation to help assess clients' emotional functioning and to assist with differential diagnosis. His specialty area is interpersonal psychodynamic psychotherapy, understanding that our problems in living often have to do with our relationships, past and present. He integrates this therapy approach with cognitive behavioral therapy, particularly when working with clients who have compulsive disorder, OCD. If there are any questions, please feel free to submit them in the Q&A function, because in the last few minutes, Dr. Friedman will answer the questions. I'm going to hand it over to Dr. Friedman.
Thank you very much. I appreciate the introduction, and I appreciate all of you who are here attending and look forward to your questions. So I'm going to talk about integrating psychodynamic and cognitive behavior therapy. And part of the reason I wanted to discuss OCD is that it can be a misunderstood disorder. And I know it's a term that people throw around a lot. You know, this person is so OCD, and it could be misunderstood and even minimized. So I want to discuss both the seriousness of the disorder as well as some ways to approach it treatment-wise. And while I'm going to talk about some theory and therapy, I'm really going to focus on cases. And hopefully that'll be a good learning and discussion experience. So let me, I want to get to the next slide. There it is. So way back, one of the first people to recognize that such a disorder existed will not surprise you that I'm going back to Freud, who observed what he called doing and undoing. And he found it very interesting that people sometimes did things, undid them, couldn't remember whether they did them, worried about whether they did them or not. And so he began to be interested in what he referred to as an obsessional neurosis. And he had a case of a person who, back in the horse and carriage days, who was driving along a road, and there was a big rock in the road, and the person decided, well, I think I could get by it, but I'm not sure that my fiancée can later on when she comes to follow me. So I'm going to get out and remove it, which he did. Then a mile or two or more down the road started to obsess. Did I do it or didn't I do it? And had to go back and make sure that they did this so that there would be no injury, potential injury. And so he started to wonder about what could this mean psychologically, that somebody would be so unconvinced that they had done something. So it goes all the way back then. We've come to understand that OCD has a psychological aspect to it, certainly, but that there's also a brain and biological component to it as well. And so one of the tricky aspects is what can we understand about the person's psychology and what may be more biologically driven. For example, if any of you have worked with people with OCD, there really has become a category of OCD known as pedophilic OCD, where people who have not in any way committed any kind of crime against the child all of a sudden become convinced and have obsessive and intrusive thoughts that they could do such a thing. So in some ways, we have found that the OCD will accuse people of something that they find to be the worst possible thing that they could do or be. So I talk with clients about OCD in the brain, and some of this psychoeducation can be very helpful. I talk with them about how psychology and biology collide, and OCD tends to activate and have us overvalue thoughts, that people have thousands of thoughts in a day. And for some reasons, the OCD makes one focus on a thought that they tell themselves is horrific and says something terrible about themselves. Like a person I met who had the pedophilic OCD, who told me, I could have a thought that I'd be a bank robber and kill people and rob a bank. I know that's just nonsense. But when I have this intrusive and obsessive thought, I worry about what it says about me. So I try and help clients understand to try to look at OCD as giving too much value to the junk mail. That if you go to your mailbox, there's important mail and there's junk mail. People with OCD and PET scans have shown areas of the brain are lit up that otherwise wouldn't be, are activated and overvaluing the junk mail. OCD also overestimates a terrible thing happening. And our brain tends to work on a 50-50 on-off kind of way. A terrible thing will happen or it won't. But people with OCD give at least a 50% chance, if not more, that a terrible thing will happen. And usually it doesn't. So, you know, if I use the example, if I'm driving home from work, I can tell myself I'll either be in a car accident or I won't, which is exactly correct. But people with OCD overestimate that potential horrific act from happening. So let me talk a little bit before I get to some cases and a little theory about what OCD is. The obsessions are the intrusive thoughts, the worries, the fears. The OCD really communicates with people that something terrible will happen. And the response to this are the compulsions for some people. Not all people have the compulsions. Some people are just troubled by the obsessions. The compulsions really are behaviors and rituals to ward off something bad from happening. So Freud saw this in, I have to go back and remove the rock from the big rock or boulder from the road, which didn't occur just once. It occurred several times with this particular client of Freud's. A client could have the intrusive thought that something terrible will happen to their family unless they do certain compulsions. So I worked with the adolescent whose compulsions included walking around the bed certain ways, touching the TV control certain ways, doing a whole host of rituals, putting the knee on the bed first before they felt comfortable that maybe this terrible thing would not occur. So you can see how this can really take over aspects of one's life, both the intrusive thoughts and the fears, as well as the compulsions that I'm going to address in some of the cases that we'll discuss together. So one of the things that I try and do in understanding the person and their obsessions and compulsions is to use a behavioral and kind of a diagnostic tool initially, is to have them develop an OCD worry map. So I asked them to develop a kind of 3-tier map. One would be obsessions and compulsions that I have bossed back and no longer engage in. Obsessions and compulsions that I have had some limited success, could be very limited in bossing back, and obsessions and compulsions that I have had no success with. And the term bossing back is really an important phrase that's used in the behavioral and cognitive behavioral work. So that one of the things we're trying to do is in some ways to externalize the OCD as a bully, as something that is trying to trick people into believing and doing things that on some level they know don't need to be believed or done. And this way it helps the person not to feel that they are OCD or that they are entrenched in it, even though it can be very ingrained. And so externalization is one part of the behavioral work. And so we try to help the person boss it back. When I've worked with kids, we may have them draw the OCD, name the OCD, make fun of the OCD. And one really bright kid named the OCD brain teaser to help show that he understood that it was really making him think things that were not necessary and trying to kind of guide his behavior. So this can be one piece of the behavioral work that we do. A very important aspect of the cognitive behavioral work with OCD, which some of you may be familiar with, is called exposure and response prevention. And one of the things that I talk about with clients is that when we alter or make even a small change in a symptom, you're taking some control over it. Here's one of the problems. Many people with OCD are incredibly critical of themselves and others. So when I worked with somebody who and I'll talk about her as a case, but one of the symptoms was, or one of the compulsions was to lock the front door over 75 times when she left the house to be safe that she had locked it, when she was locking it more like 15 times at one point. Her response was, big deal. Normal people don't lock it more than once. And my response to that was, well, I don't know, but normal people do other things too. And talked about how hard they are on themselves about the changes that they've made with this. So what is exposure and response prevention? That falls into the category of, if every time I pass the bathroom, regardless of whether I need to use it or my hands are dirty or not, the OCD tells me something bad will happen if you don't go in and wash your hands. What happens is a lot of clients will avoid walking by the bathroom. And in avoidance, you're really giving in to the OCD because you're avoiding part of your living space. So what I'll have them do is to expose themselves to walking by the bathroom. And if they feel compelled to go in, to wash their hands for less time than they ordinarily would, so that they're preventing the longer term response and altering it in some way, with the ultimate goal of helping them to be exposed to something and eventually not feel a need or resist washing their hands. Some of what can help with this too is also initially teaching them some relaxation techniques, stress management, distraction, ways that they have tools in their toolbox to help them prevent the response. Some clients with severe OCD often need medication in addition to the psychotherapy, and those tend to be the SSRIs. The interesting thing is we have found that people with significant OCD often need a higher dose of the SSRI than they would need for clinical depression. So exposure and response prevention certainly is an important aspect of working on the OCD. And sometimes I've done this with kids, with their parents, in the office with hand washing, or I had one child who, when he took off his seatbelt in the car to come into the office, needed to put it on and take it off many, many times. So we worked together to battle that. Another important behavioral aspects of this, we want to help people, as I mentioned, challenge the OCD and help them alter the thinking, the behavior, and the ritual so that they're not avoiding it and also not trying to negotiate with the OCD. A lot of people will negotiate with it. Well, if I do it, will the terrible thing not happen? And one of the problems with that is, if you obey the OCD and you engage in the ritual and the terrible thing doesn't happen, which it wouldn't generally anyway, the brain becomes even more convinced and reinforced that the compulsion stopped the terrible thing from happening. And this is an important thing to help clients understand, because they become magically convinced that nothing bad has happened because they obeyed the OCD and engaged in the ritual. An example was, I worked with somebody who was a school teacher and was convinced that if she cleaned the tables in the lunchroom certain ways and so many times, nobody would die from a peanut allergy. And so people can become convinced that they have excessive responsibility in order to stop something terrible from occurring. Some of the other CBT interventions that you may be aware of that can be very helpful with OCD are helping the client to become aware of and to challenge automatic thoughts. And in these cases, these automatic thoughts tend to be very OCD related. They tend to be very kind of coalesced around OCD. And to work on the cognitive distortions that feed the OCD, including the all or none and magical thinking. If I don't do this perfectly, then something terrible will happen. If I do it exactly this way, then I will, the fates will let nothing happen. And we also have to look particularly for the core beliefs that I call OCD friendly, including I am bad, the world is dangerous, bad things happen all the time. People with OCD, and we'll get to the psychodynamics in a moment, often have an underlying struggle with, am I a good or a bad person? Because they cannot tolerate both ambiguity and also the fact that we have ambivalence, that we can love and be very angry with people at the same time. Sometimes they feel that makes me a terrible person if I have any anger or rage at somebody that I also love. So there's a whole host of CBT interventions that are generally used with anybody that we see, but we want to focus particularly on OCD kinds of things, like the all or none thinking and the magnifications. If I make a mistake, then people will be hurt because of it, which I'll discuss in a case. So just a kind of bit summary, cognitive behavioral model looks at the intrusive thoughts that people have and try to evaluate what these intrusive thoughts are, help the person understand overestimation of dangerous situations, help the client consider exaggerated responsibility and guilt that they have for things. And a very important one as well, take a look at perfectionism and need for control. Perfectionism can be a very, very complex and difficult kind of problem because people who are perfectionistic never feel that it's good enough, and they also may feel others in the therapy are never good enough as well. So I mentioned Freud's doing and undoing, which he also called, and I don't know the German word, how to say it, making unhappen, which was pretty clever that he recognized. And making unhappen can be, I've had clients who will recite the alphabet backwards if they feel they've had a sexual thought that they're uncomfortable with, or an aggressive thought that they're uncomfortable with, and they feel a need to undo it. A question from the psychodynamic perspective is, why would that particular thought, as opposed to other thoughts, make you so uncomfortable? Again, we have thousands of thoughts. Don't people sometimes have angry or aggressive thoughts? Don't people sometimes have sexual thoughts? Don't people sometimes have loving or tender thoughts? Why would that person need to undo a particular kind of thought through a compulsive ritual? As I mentioned earlier, another psychodynamic concept that kind of collides psychology and biology, because many of us look at OCD as a disorder of doubting, struggling with ambivalence. Am I a bad person for having mixed emotions and feelings about others? I don't know if any of you have worked with folks where you've come to realize that they really struggle with the idea that we can be very angry with people that we love and care for, and it doesn't make us a bad person. And some of this comes from childhood and how tolerant parents and other caregivers were for ambivalence and anger. So a disorder of doubting. Overestimation of thoughts, but also from a psychodynamic perspective, we talk about magical thinking. There are folks who are not aware, but they are treating thoughts as the equivalent of action. Thoughts are good or bad, therefore I am good or bad. If others knew my thoughts, they would be disgusted by me. I hear this quite often from people with OCD. They would be disgusted with me, as if none of us ever had thoughts that weren't aggressive, sexual, or whatever. And also a real difficulty with tolerating ambiguity, things not being just one way or the other. A disorder of doubting. Is it this way or is it that way? I'll give you a quick example of thoughts and punishment from the OCD. I worked with a fellow years ago who was a college student, And he was very ashamed of his sexual feelings that we were working on and found it very difficult to talk about them. And had a niece, a 4-year-old niece that he loved a great deal and often watched when his sister was working as a nurse, and never did anything inappropriate, never thought about that. And then after he was looking at pornography, which always made him feel ashamed and like he was a horrible person, he tearfully said to me that I'm going to think he's terrible because when his niece came over a few hours later to be watched by him, he had this intrusive thought that he could do something hurtful or sexual to her, and waited for me to be judgmental towards him. And my response was, boy, that OCD can be a real, and I said quite a word to describe it, because it is a bully, and it punished him by making him think such a thing was possible of himself. This is something that people with OCD live with. So in the psychodynamic model, there's a lot of different aspects to it. One of the things from an interpersonal model that I work with is to help clients see that because of the OCD, their psychology and biology, for example, they are seeing an internal wish or a need or an intention towards another person. They're internally experiencing it as shameful. Whether it be a need for a sexual need, a need for love, a need to feel valued, for some reason, this person is experiencing their wish and thoughts of what they want from another person as shameful. And the OCD, the compulsion, is an attempt to avoid acting on the wish that has been seen as shameful and punishing of the person. And so part of the interpersonal psychodynamic approach is helping them understand this and exploring what makes this wish towards another person so shameful that there needs to be countermeasures taken that are very, very uncomfortable and punitive. So now, there can be a childhood scenario that's being reenacted, and the OCD symptoms may relate to that childhood scenario and also can be an attempt at control. Rituals can be an attempt to control something in childhood that was traumatic and could not be controlled. And I'm going to discuss this in a case in a moment or two. So there can be a childhood scenario that's being reenacted and the OCD related to it. And it can be an attempt to control something that was uncontrollable in childhood. Okay, so that's some theory. I'm going to talk about some client cases, at least two, I hope. And the first case I call "My mistakes and inaction can cause great harm." So I worked with this woman years ago who was a nurse. And she, by all accounts, was incredibly talented at it and worked in an emergency service and also worked on other floors in the hospital. And she came because she said, my OCD is totally out of control. I've got to do something about it. And Dr. Friedman, before you suggest medication as a possible thing, my husband and I were trying to get pregnant, and I really don't want to go that route. So what can you do to help me? And her OCD included, she lived with her husband and a dog. The OCD included before she left the house, because she got up before him, if she didn't touch and kiss him in a certain way, then something terrible could happen to him. She had to not only make sure nothing was on with the stove and the oven with the handle, she had to put her hands on the burners. She had to turn on and off the hair dryer. She had to do all kinds of things over and over again. She had to make sure that neither her husband or the dog would die in a fire when she left. She had to make sure that the dog couldn't get out. So she had to lock the door many, many times, even though the dog doesn't have opposable thumbs and can't open the door. She had all kinds of things. She had to go to her car and she had to unlock it and open the door and do that many times. Sometimes she had to go back to the house and make sure the door was locked. Sometimes she had to go in and check the burners. So she had to prepare for going to work a lot longer than when she had to get there. Then she also shared with me that her husband was aware of this, and that at times, if she worked with a very ill patient in the hospital, even though she did what she needed to do as a nurse, she would come home, and even though another nurse took the next shift, her husband had to tell her, no, you can't call the hospital at 2 a.m. and say, is patient so-and-so still alive? You're going to look out of your mind, because she worried, did I do that last procedure correctly? Did I dress the wound correctly, or did they have an infection? So it was always what I did and didn't do could cause great harm. So we worked together using cognitive behavioral work. We looked at core beliefs and distortions. We used exposure and response prevention. We limited the number of symptoms, behaviors significantly. One of the ways that's pretty simple, if a person can benefit from it, is if you lock the door and you say out loud in your head, or if nobody else is standing there, I just locked the door, you're creating a neuronal trace in your brain that may help with some doubt. We did a lot of work and she was improving a lot. But there was a lot of work to be done. So we did a lot of exploration of this excessive responsibility and this feeling that whether you do something or don't do something, great harm can come. Is this familiar to you elsewhere outside of your home and your dog and your husband and outside of the hospital setting? And we learned together, we talked together about when she was growing up, her dad, who was an alcoholic, you never really knew to some degree which dad you were getting when he would come home. And at times, her younger brother would make the mistake of standing up to the dad or standing up to the dad if he got physical with their mother. And she became the person, told herself it was her responsibility to stop the brother from doing this so that he wouldn't be hurt. And of course, she couldn't control him. So sometimes it didn't go well. And she even mentioned to me, it's interesting that from trying to help and take responsibility, I went into a medical field in which I'm trying to help people from having worse things occur to them in some way. Maybe that partly drove me to that field. As much as I love it, it's causing me a lot of grief. I need to see it differently so that I can feel when I leave, there's another adult to care for the patient the way my parents weren't able to care for us. And my mother couldn't stand up to the dad, understandably, and my dad was not a responsible parent, which was a great insight to be able to have. There are other adults in the room. I don't have to call the hospital. And I don't have to feel like the dog and my husband are going to be injured because I can't make everything perfect and better. And so when we dealt with some of these earlier childhood feelings and experiences, it made the cognitive behavioral work even more useful and helped her to continue to make benefit of it. And so I give that as an example, and I'd be glad if there are questions about it, that the combination approach of looking at also the magical thinking that she felt ashamed of came up in the therapy. I wished my dad would die. What kind of a person did that make me as a child? And sometimes when she got angry with her husband, she would think, boy, it would be better if you would just disappear, even though she really loved him and never wanted him to disappear. But we all at times, I mean, that's why we have doors and rooms in a house. We all need to get away from people, and we can love them and be angry with them. So you can see that her fantasy and her psychodynamic life and her cognitive behavioral life were combining to need to be dealt with this problem. The other case that I'll mention is a college student I worked with who had one of the most severe cases of rituals and of cleanliness, and couldn't live in the dorm because of fears of dirt and contamination, and got a waiver because the college required living on the dorm for freshmen, lived in the same state, the state I'm in, and lived at home. And the father enabled him in showering rituals, and the father had a history of OCD. And it was all about cleaning and germs and really taking the family hostage with this. And he couldn't go into the cafeteria often at school because of germs. When he did, it was like the movie As Good as It Gets with Jack Nicholson. He brought his own plasticware, sat away from people. We used exposure response prevention, dealt with some core beliefs, distortions, exposure response prevention, worked with his dad as the enabler. And we were doing a lot of cognitive behavioral work, and which I often start with. And then asked him a simple question. I said, make up a name. I said, John, as we're working, and this is moving forward, but there's a lot of work to do. Some people with OCD, they really tell themselves that there are certain thoughts, fantasies, wishes, words that are so horrible to have. Does that make any sense to you? And without skipping a beat, he looks at me and he goes, you mean the lustful thoughts? I said, well, that would be them. What do you mean by the lustful thoughts? Well, if I find a young lady attractive at school, I tell myself what a bad person I am, and I'm objectifying them, and sex before marriage is terrible, and I shouldn't have these feelings. And my response was, it's enough to make you stay out of the cafeteria. Because, yes, in addition to dirt and germs, he was seeing his own wish and thoughts as dirty and shameful. And if you don't go in the cafeteria, you're not going to see perhaps a young lady that you have interest in getting to know and talk to. And then, interestingly, because there can also be family dynamics, he's living at home and his bed contaminated. But for some magical reason, he's spending a fair amount of time sleeping with his two parents as a college student. And when I meet with the parents alone, I say to them, I imagine you know what I'm going to ask the two of you. And they said, Dr. Friedman, we have no idea. And I said, is there ever an opportunity for the two of you to be intimate? And they looked at me like I was out of my mind, because he's in the bed with them. Well, he's also maybe to some degree serving a family purpose of keeping them from having to deal with each other as human beings. And maybe some of his feelings about sexuality and intimacy came honestly to him from some perhaps parent problems or their own inhibitions or difficulties in this area, which I hope illustrates combining an awareness of both the psychodynamics and the cognitive behavioral. And in terms of transference, you know, he could see me if I'm prematurely trying to get him, what's so wrong with talking to a young lady, as taking the position that he is finding so disgusting or distasteful, and see me as bad in some way by trying to encourage him to do the very thing he's trying to defend against and not do, which I tell students is one problem of just suggesting people do things they're avoiding. Maybe there's a good psychological reason that they're, or at least in their head, that they feel they need to avoid whatever it is. Telling somebody who sees assertiveness as aggressive and horrible to be assertive is not going to sit well with them until we help them understand them seeing assertiveness as so horrible to do or be. So it helped the work in which we were combining looking at the behavioral, the thoughts about germs, but also the shame and guilt about the whole idea of attraction and dating and talking and trying to be interested in getting to know somebody. And in the case of the person who, one of the people who came to me with the pedophilic OCD, who was a college student, she never did anything inappropriate, didn't even like kids, didn't think she wanted to have kids. But in addition to doing the behavioral work, the psychodynamic work together helped bring out that one of the things that she struggled in life was, yes, being loved by her parents, but always feeling less valued by her dad than her younger sibling, female sibling, because the dad and the sibling related on athletics. And the sibling was incredibly athletic, but my client was more artistic. And the dad and the daughter would do athletic things a lot and go camping. And so for her, I could harm a child, look what a terrible person I am, even saying to me, my boyfriend, who was another college student, looks kind of young. So this must be evidence, quote, evidence that I want to do something to a child. I'm like, what kind of distortion is that? My boyfriend looks kind of young for his age, so that means I must be a pedophile. This was kind of hiding from her, although torturing her, some of the intention, the wishes she had at times that something could happen to her sister and get her out of the way so that she could be more of the apple of the dad's eye. Now, did she also have love for her sister? Sure. Did she really want something terrible to happen? No. But was she at times enraged, jealous? And this was unacceptable to say or to show because of the close relationship with the dad and the sister. And so it became embroiled in an OCD kind of, I'm a bad person, I have ill will towards a child, I want to hurt a child, became depressed over it, hard to function in school, had to stop being intimate with the boyfriend. So I hope that these cases give you some sense that this can, sometimes the cognitive behavioral and the exposure response prevention work may be sufficient. Other times, Other times you need to really do some more in-depth digging, so to speak, and combining approaches. So let me stop at this point and see what questions or comments there may be, and ask my colleague to help with that.
Hi, very nicely done. Thank you, Dr. Friedman. So a first question is, could you please discuss the benefits and the cons of working with treatment and medication together?
Yeah, well, medication isn't needed for everybody, and some people certainly want to try a trial of medicine, a trial of psychotherapy first. The research shows that both for major depression and for severe OCD, the combined approach tends to be more efficacious, partly because of how ingrained the OCD is. And we find that the medications that enhance the availability of serotonin seem to calm it down somewhat and let the people be more available for the therapeutic work. And so that's why we recommend it. But not everybody is open to it. Some people with OCD who are very hard on themselves hear the discussion of medicine as you're telling me that I'm defective, and they incorporate that into the OCD and the perfectionism. So one may have to address that.
Okay, thank you. The next question is, they wanted to know if you could touch a little bit of the difference between OCD and OCD personality disorder, and if the
Yes.
treatment would be similar.
Very good question. Yes, they are similar. The OCD personality tends to be more somebody who is rigid in some ways, needs to do things in an orderly manner, but doesn't necessarily, it pervades kind of what they're like with people, but they may be less affective or emotional, more intellectual. Um, by the way, we all have personality types, and hopefully they don't become rigid enough to become disorders. But a great book on personality types was written by David Shapiro many years ago called Neurotic Styles. And he talked about, imagine a couple where one person has OCD traits and the other person has histrionic, overly emotional traits, and see how they get together. But the person with personality obsessiveness usually doesn't have those kinds of rituals. They tend to just be rigid in terms of lack of emotion, over intellectualized, things should be done, big planners, not spontaneous. Sometimes you treat it similarly. You certainly want to look at the core beliefs and understand what in growing up made that be rigid, and are they anxious about loss of control, for example.
Okay. Another one is, have you found an increase in OCD symptoms since the beginning of COVID-19, given the requirements within society, especially with Ontario, Canada, to utilize hand sanitizers upon entry to any and every establishment?
Yes, we've seen people who had and struggled and made advances with it obviously struggled tremendously during this period of time, but also people who weren't not necessarily a full-blown OCD, but certainly develop traits of this because there is good reason to be careful, when we're told that, the environment has some dangers. And, when this first happened and we didn't know about transmission, people were washing their grocery bags and their grocery items when they got home, because we didn't know what was how this was transmitted. So and the social isolation has created some degree of rigidity, obsessiveness, and depression.
When starting with a CBT and treating OCD, how do you gauge when to use a psychodynamic approach?
Well, being honest, I tend to think psychodynamically even when I intervene cognitive behaviorally, because that's my kind of way of trying to understand people and conceptualize. But when I use the cognitive behavioral work, if I feel and discuss with the client that the progress, we've reached a certain point, but we need to go further because there are some things getting in the way of it working the way we had hoped, then I would tend to uh, incorporate or integrate more of a psychodynamic approach. If it's going really well and it seems not to be always needed, then we may touch on some things, but I'm not going to do that as much. So I think I always start. I discuss different ways of working, and I always discuss some of the cognitive behavioral ways and how we'll collaborate, and tend to begin there.
Okay. Can you talk a bit about self-rejection as it relates to OCD? Is this generally common, or does it tend to manifest with certain types of OCD?
Well, if I understand the question, I mean, I think that being very hard on oneself and for the thoughts and feelings and not being good enough, I think tends to be a pervasive thing. But I think, and it's a complex topic, I think that this partly also depends on the attachment patterns of the person. And people, whether they have a secure attachment or an avoidant or an insecure attachment, because I think people who have insecure and avoidant attachments tend to be more self-rejecting to begin with, and they tend to be harsher and maybe tend to bring negative feelings to the transference in the therapy as well. And so, yeah, it's a good question, I think, but I think there is a core, am I a good or a bad person, underneath a lot of this.
Is it common for symptoms to become severe enough to require hospitalization? If so, what does hospital treatment look like in comparison to an outpatient treatment?
It's a great question. The answer is yes. Years ago, I saw an adult with a very elderly mom come to my office, and he was wearing, people in the waiting room were a little freaked. This was way before COVID, was wearing hospital gown and gloves and a mask and all kinds of things. The rituals were incredibly excessive. There were some delusional thoughts about if my saliva got on somebody, they could read my thoughts. It became very entrenched and with some psychotic aspects. Fortunately, the mother had a lot of money. I recommended an OCD inpatient facility. I was in Philadelphia and in Boston, Massachusetts. Fascinating family dynamic. When I'm alone with the fellow, he says to me, by the way, I just want to mention, I spent some time at friends in another state away from my mom. And while I had a lot of symptoms, there seemed to be a little bit of a lessening of them. And since I wasn't going to work with him and get into it with him, I just said, that's fascinating. I think you should tell them that at the hospital. And certainly the hospital was going to separate the two for a period of time. But in the hospital setting, they have the ability to control your environment. So they can help with the exposure and response prevention and the anxiety that comes with it by being there with you. And also adjusting medicine and having group therapy for support, where I can't outpatient control anybody's environment. I have enough problems controlling my own. So that's an additional boost for some people who it's very complex.
We have time for one more, and I'm going to combine it because it's related. One is relapse for clients with OCD behavior common? And how do you work with the client that experiences the relapse?
Great question. It is, and we discuss, and I appreciate the question. I talk about it as relapse management because prevention is a word that will freak out people, particularly OCD people, because they're like, you think I could prevent uh, things from happening. What I discuss with them are the skills, what could activate it? What are the skills they would use? And I'll give you an example before we close that I just gave in a class I'm teaching. I worked with a fellow who had severe OCD and unfortunately Tourette's. And at the end of the therapy, he said to me, what if some of this, I got a lot of it under control, not all of it, but what if some of it gets worse? And since he liked Christmas a lot, and I said, what you and I did to some degree is we rewired some of your brain the way you might rewire a Christmas lights around the house when a light is flickering too much. And now you have some of the skills that if you realize a light in you is flickering a little too much, how would you go about dealing with recognizing it and helping to manage it? So we talked about some of those strategies for his brain Christmas lights. And so relapse management is critical because under stress, things will activate OCD and magical thinking that, for example, I'm being punished for something.
Okay. Well, I want to thank you and everyone else who came. If you have any questions, you can email events@yorkville.ca for any questions regarding this presentation. The PowerPoint will be sent out later today or by the end of the week. Dr. Freeman, do you have any closing words that you would like to say?
Well, thank you. Thank you, Alyssa, and thank you all for participating. And I hope it was a good learning experience. And feel free to, email me if you'd like any references or resources. So thank you all. I appreciate your time and being a part of our learning.
Is your email in the presentation?
Yes. I don't remember. It's S. Friedman, SFRIEDMAN @yorkvilleu.ca.
Okay. Well, thank you again. Enjoy the rest of your day, everybody.
Thank you.